Hi, our topic today, we are presenting on traumatic loss and grief disorders, presented by Erin Hopper Sanchez and Taisha James, myself. Learning objectives include we would like for you to be able to examine clinical findings to accurately diagnose prolonged grief disorders based on the DSM-5 criteria, identify symptom variations of grief across the lifespan, and assess and identify barriers to treatment. Grief disorders. Symptoms overlap with other psychiatric conditions, including depression disorders, separation anxiety disorder, and PTSD. Acute stress disorder. Symptoms occur within 3 days to 1 month of the stress or loss. Adjustment disorders. Symptoms occur within 3 months of stress or loss. Acute is less than 6 months, and persistent 6 months or greater. And then we have prolonged grief disorder. Prolonged grief disorders is the death of a person close to the client at least 12 months ago for adults, 6 months ago for kids. Persistent grief response includes intense longing for the deceased person and or preoccupation memories of the deceased person. It requires three of the following: identity disruption, sense of disbelief for death of the death, avoids reminders of the person, intense emotional pain and numbing, loneliness, or difficulty in reintegrating into relationships and activities. The grief causes clinically significant distress or impairment in important areas of functioning. Duration and severity of bereavement reaction exceeds expected norms, and symptoms are not better explained by another mental health disorder. Traumatic loss. It's not under the DSM-5 diagnosis of prolonged grief, but it occurs with the death of a loved one, happens under unexpected circumstances, and could be sudden or violent. Examples include suicide, accidents, homicide, or natural disasters. Can lead to traumatic grief, in which trauma symptoms can disrupt the mourning process. Some symptoms include intrusive memories, avoidance, emotional distress, increased arousal, and loss of faith. Variations across the lifespan. While the core symptoms are similar, there are some differences in how prolonged grief may manifest in children and adolescents versus adult. With children and adolescents, they may also show symptoms such as mood changes, sadness, fear, concerns about losing other loved ones, separation anxiety, focusing on the death circumstances, or having vivid flashbacks of the death experience. With adults, they may experience social difficulties, a profound inability to accept the loss, increased substance use, or suicidal thoughts. The variations with children include the management because each stage of life has different developmental tasks, stressors, and social contents that impact how loss is processed. Children express grief through play, regression, or somatic complaints. Their treatment is tailored to the child's developmental stage, providing reassurance, maintaining routines, and age-appropriate explanation of the death. With adolescents, they may be intense and have feelings expressed by anger. They may have risk-taking behaviors and withdrawal. They may discuss their feelings more with their friends and peer groups rather than family and parents. Treatment is based on support groups and open communication. With adults, symptoms may present as depression and or anxiety, strained relationships, and affect daily functioning. Treatment includes counseling and support groups. With older adults, this demographic is highest for suicide. They may have experienced multiple losses of family members and friends. Grief may be also the result of their loss of independence, physical health, and social connections. Their treatment is focused on maintaining social connections, their independence, continuing interests that bring them joy, counseling, and support groups. Screening tools for grief disorders include prolonged grief disorder questionnaire. It consists of 13 self-reported questions that determine a probable diagnosis. If item 3 is yes, symptoms have persisted at least 6 months, and the total symptom score is 35 or higher, it suggests probable prolonged grief disorder. Then you will check to see if symptoms are causing significant functional impairment. A yes to question 13. A brief questionnaire. Brief Grief Questionnaire is a 5-item self-reported tool used to quickly assess symptoms of complicated or prolonged grief in individuals who have experienced a significant loss. A score of 4 or more suggests that the individual may be experiencing complicated grief. This indicates a need for further assessment with a grief specialist. The inventory of complicated grief consists of 19 items designed to identify and quantify the symptoms of complicated grief, differentiating them from other diagnoses. Scores of 25 or above suggest that the individual may be significantly impaired in their daily functioning related to grief. The structural clinical interview for complicated grief has 31 items. It's clinician administered, developed to assess symptoms of complicated grief, also known as prolonged grief disorder. It helps to facilitate the diagnosis. Total scores range from 0 to 76. Higher scores are associated with a more severe or complicated grief. It can also be used to track changes in treatment. Pharmacological treatment. No specific medication known to have a direct effect on grief symptoms. There have been studies about naltrexone, but it's not FDA approved for grief, but it may help when the person obsessively focus on the deceased individual. To manage symptoms of grief, symptoms are also usually related to PTSD, MDD, anxiety, suicide ideations, and the suggested treatment is with SSRIs and tricyclics. Non-pharmacological treatment includes complicated grief treatment, which is the gold standard for the treatment of PGD. It involves 16 sessions that incorporates attachment theory, cognitive behavioral theory, and other approaches to assist with the natural adaptive process of loss. Cognitive behavior therapy focuses on identifying and changing maladaptive thought patterns and behaviors that prolong distress and hinder adaptation to the loss. Techniques include exposure therapy to confront avoided memories and feelings, cognitive restructuring to challenge unhelpful beliefs, and behavioral strategies to re-engage with life and build social support. Treatment aims to help the individual accept the reality of the loss, adapt to their new life, and integrate grief into their current life. Ethical and legal considerations. Ennis defines traumatic loss as the unexpected or violent death of a loved one. Keeping this in mind, providers must ensure that they are sensitive and respectful to the person that has experienced this loss. Ethical principles that help balance professional boundaries and care include informed consent, confidentiality, empathy, cultural sensitivity, professional boundaries, and ensuring the person's well-being. These principles help guide the integrity of the therapeutic allowance. We must also explain legal obligations such as our duty with reporting, which often overlaps with these ethical principles. And the specific laws that vary by jurisdiction. Disclosing information is only when necessary, such as in cases of imminent harm to the client or others. These limits of confidentiality should be discussed at the onset of therapy. This includes informing clients about mandatory reporting requirements and any situations where confidentiality might be breached. Informed consent is another ethical principle in trauma therapy. It involves ensuring the client is fully aware and understands and agrees to the nature of the therapy, including methods used, potential risks, and benefits. Informed consent is an ongoing process requiring a therapist to provide clients with updates and new information throughout their treatment. Therapists should engage in clear and transparent discussions with clients about their treatment plans, goals, and any potential impacts on their well-being. Therapists must practice within their area of competence, ensuring that they have the necessary skills and knowledge to address the specific needs of clients dealing with trauma. This involves staying current with best practices and evidence-based approaches for trauma therapy. If a therapist encounters a case that exceeds their expertise, they should refer the client to a specialist or seek supervision. Barriers to treatment related to culture and socioeconomic factors. Culture and socioeconomic factors can present significant barriers to treatment of individuals experiencing trauma loss, as cultural influences how grief is expressed, viewed, and managed. Individuals of different cultures have different beliefs about death, may experience grief differently, and may have rituals unique to their culture that impacts how they will cope. In clinical settings, assessing cultural factors can help avoid misunderstandings and ensure that support aligns with the bereaved culture's needs and expectations. Acknowledging these differences allow caregivers to offer personalized assistance and validates and honors their grief process. Lack of cultural competence can lead to ineffective interventions or exacerbate feelings of isolation and guilt. Cultural barriers, stigmas against mental health. Cultural values such as emotional strain and self-reliance, internalize symptoms rather than seek help. The distrust of healthcare, example of the Tuskegee experiment, in which the minority communities continue to distrust healthcare. Different perceptions of grief, meaning of the illness, cultural differences can lead to confusion and misunderstanding between patients and providers. We must ensure that questions are asked to clarify cultural differences. Their mourning practice. Again, ask questions to clarify differences and misunderstandings, as misunderstandings can lead to interventions that are not appropriate. May require you to do some homework to understand the cultural more, to understand how their grief is expressed. Socioeconomical barriers, the high cost of clinical treatments, financial strains. Those with lower income often face chronic strain of financial stress, which can lead to exacerbation of mental health issues and make it harder to prioritize their care. Inadequate insurance and limited to resources. They may not have transportation to get to therapy or may need childcare and other resources that hinder them getting care. The role of the psychiatric mental health nurse practitioner can improve outcomes by providing trauma-informed care using evidence-based therapies, offering holistic symptom management, care coordination, and collaboration. Trauma-informed care seeks to promote safety and prevent re-traumatization by recognizing the signs and symptoms of trauma and understanding the pathway to recovery. The use of evidence-based therapy helps to guide the individual through the grief process in a way that is unique to their individual needs. Partnerships and collaboration between the disciplines is seen as a strength, as everyone seeks to care for this individual holistically and improve their health outcomes. Thank you for listening. These are our references.